Assalamu alaikum everyone. Now we should discuss hereditary spherocytosis, which is a type of hemolytic anemia, and it is non-immune mediated hemolytic anemia, which is due to intrinsic defect in the RBC membrane. It's the most common congenital hemolytic disorder among individuals of Northern European descent. Etiology: so congenital RBC membrane protein defect, and it's autosomal dominant in 75% of cases, while recessive in 25% of cases. So most commonly it's an autosomal dominant disorder. Family history is often positive for relatives who required splenectomy and or developed cholelithiasis at a young age. So the patient usually have a family history of splenectomy and or developed cholelithiasis at young age. The affected protein are spectrin and chirin and band 3 and also a little beta protein 4.2. Pathophysiology: so genetic mutation, gene defect in RBC membrane protein, especially spectrin and R and chirin, which are responsible for tying the inner membrane skeleton with the outer lipid bilayer. So continuous loss of lipid bilayer components decrease surface area of the RBC in relation to volume. Sphere-shaped RBC with decreased membrane stability, inability to change form while going through the narrowed vessel. The entrapment of RBC occur within the splenic vasculature, leading to splenomegaly, and destruction via splenic macrophages, leading to extravascular hemolysis. Clinical features: so its presentation is variable. In mild hereditary spherocytosis, which is 20 to 30% of cases, they are often asymptomatic. In moderate, which is most common, 60 to 75%, the onset of symptom is usually in infancy or childhood. Severe hereditary spherocytosis, which is 5% of cases, onset of symptom in newborns or even in utero, leading to hydrops fetalis. Other symptoms are anemia and pallor, jaundice due to unconjugated bilirubin, splenomegaly with left upper quadrant pain, and black pigment gallstone made of calcium bilirubinate may lead to cholecystitis. Now lab findings: so it's a normocytic anemia. MCV will be normal range between 80 to 100 femtoliter or slightly decrease. Increase MCHC. This is the specific finding for hereditary spherocytosis. The elevated MCHC is due to the decrease in RBC volume, usually caused by a decrease in RBC water content, whereas hemoglobin content remain constant. So the concentration of the hemoglobin is elevated in hereditary spherocytosis due to decreased volume of the cytoplasm. Increase RDW and the increased reticulocyte count. Normal range is 0.5 to 1.5%. Finding of hemolytic anemia will be present in increased unconjugated bilirubin, decreased heptoglobin, and increased LDH. Using 5 in lab test, using 5 melamide binding test. It is the test of choice, and results are available within 2 hours. Decreased binding between dye using 5 melamide and RBC membrane protein. Binding is quantified using flow cytometry, which show decreased mean fluorescence. So there is decreased binding between the dye and the RBC membrane protein. Using dye usually bind the different type of proteins, but in hereditary spherocytosis the protein content reduce, so the binding between the dye and the protein is also reduced. Other tests may be used like Coombs test. So Coombs test will be negative because it's a non-immune mediated hemolytic anemia. It is used to exclude the autoimmune hemolytic anemia. In autoimmune hemolytic anemia, we have positive Coombs test since spherocyte is seen in both. As we have already discussed that spherocytes are seen in both autoimmune hemolytic anemia and in hereditary spherocytosis. To distinguish between them, we use the Coombs test. So Coombs test is positive in autoimmune hemolytic anemia, while it's negative in hereditary spherocytosis. Then we have positive osmotic fragility test, measure the ability of RBC to resist hemolysis when exposed to different degree of salt dilution. Example: RBC swell and eventually lyse when incubated in hypotonic saline due to water influx. So whether or not RBC depend upon their surface area to volume ratio. The ratio is reduced in patients with HS, so the RBC are more fragile and more vulnerable to osmotic stress. When we put these cells in hypotonic solution, so the water from the solution start to move to the cells, and these cells are unable to bear those osmotic stress, so they ruptures easily. Then we have acidified glycerol test, so RBC are incubated in a hypotonic solution to which glycerol is added. The test is positive. The patient's spherocyte lies more quickly than normal RBC, has greater sensitivity than classic osmotic fragility test. On blood smear, there will be spherocytes. Normal RBCs are biconcave shape, but in hereditary spherocytosis they become round shape. Characteristic spherocyte small round cell without central pallor. So this is a spherocyte while this is normal RBC biconcave shape. Normal erythrocytes are visible as donut shape with central pallor, while spherocytes lack central pallor. Potentially, there will be anisocytosis, like RBC will be of different sizes. Ultrasound can be used to evaluate gallbladder complications due to gallstone formations, like cholelithiasis, cholecystitis, and cholangitis. Treatment of hereditary spherocytosis. So we have non-surgical treatment and surgical treatment. Non-surgical treatment we can do phototherapy and RXN transfusion may be necessary in neonates. Example to avoid kernicterus. Blood transfusion may be required in some cases, and folic acid supplementation to maintain erythropoiesis. Splenectomy is the sole definitive treatment. So you have to remember that the investigation of spices using 5 melamine binding test and the treatment of spice here is splenectomy. Prior to the procedure, vaccinate against strep pneumo, Haemophilus influenza type B, and Neisseria meningitis. In hereditary spherocytosis have different complications like hemolytic crisis, especially as a result of viral infection, aplastic crisis following infection with parvovirus B19, also known as erythema infectiosum or fifth disease, which is characterized by low retic count, less than 0.1% of total RBC count. Megaloblastic anemia can also develop as a result of folate and B12 deficiency and megaloblastic crisis due to folate deficiency. Although uncommon in developed countries, it might still be seen among pregnant women. Other bilirubinate gallstone formation possibly leading to cholecystitis, cholangitis, and pancreatitis, and growth retardation and skeletal abnormality due to bone marrow expansion. So that's all about hereditary spherocytosis.